Good morning. My name is Guy Diamond. I'm a suicide prevention and treatment researcher, been working in the Philadelphia area and across the nation for the last 30 years. I'm here to share with you a little bit about our intervention work with attachment-based family therapy. I'm going to talk a little bit about the theory of the model, a little bit about the clinical structure of the model, and then actually going to show a videotape at the end to give you a little taste of the clinical structure and texture of the work. So let's get started. The ABFT International Training Institute has recently been launched. It is from there that Suzanne Levy and myself are conducting all kinds of national and international training in attachment-based family therapy, really a method for strengthening family connection and building family as the safety net as kids move through a suicidal episode. We do have some disclosures. She and I have been working for years. We've received funding from the National Institute of Health, American Foundation for Suicide. We have a book we get small royalties from and occasionally get paid for giving a talk. These are the three collaborators who have really pushed this model forward over the last 15 years. Myself, starting at the University of Pennsylvania at Children's Hospital, and then 10 years at Drexel. Gary Diamond, not related by blood, but a academic soulmate, has been primarily at Ben Gurion in Israel, doing this work, particularly with the LGBTQ young adult population. Suzanne Levy has been the executive director and now the CEO of the ABFT International Institute. She is a trainer excellence. And if anybody needs more information about us, she's the main contact. Below are a few of the old websites. I have to update this a little bit, but you get some of them. This is the book we wrote in 2013, still stands as the definitive document of the ABFT model. It's a manual, it's a training book, it's inspiration, it's concrete ideas about how to move forward in therapy. We are in the process of writing the next book now. What are some core elements about the work that have made it distinct? First, it's a brief treatment. We live in the land of empirically supported treatments. We've been funded to do a number of randomized clinical trials, and the requirements of those studies are therapies have to be short enough so that you can measure pre-post outcome and maybe even long-term outcome. So a lot of treatments have moved to a 12-week, 16-week model, CBT, DBT, ABFT, and we are part of that tradition. We also find, however, that we like brief treatment, that families like it, patients like it, they feel like this is a defined set of time, I'm not here forever. But most of all, what we like is that therapists have to work harder. Every session counts. I can't sit and talk about prom for an hour. I have work to do. I have goals to meet. I have outcomes to get to. I have conversations to develop. So we find the brief treatment model helps increase therapists' intentionality and urgency. The model's been developed specifically for depressed and suicidal teens. And when I get a referral for a child like that, I feel like it fits like a glove. I know a lot of the processes that are going to present to me. I know a lot of what I'm going to see in the room. Not every family is different, but it gives me a scaffold to know where to go. In the latter years, 10 years or so, the model, however, has been adapted. We've been working with eating disorder, trauma kids, younger children, younger adults, and it's become a more transdiagnostic model applied to a variety of populations. The distinct characteristic of the model is that we've taken family therapy, which we know can be a sometimes wild and woolly process. A lot of people in the room, a lot of individual needs, a lot of different needs. And we have tried to organize the core mechanisms of change into 5 distinct interrelated tasks. Tasks are not sessions. Tasks are things you're trying to accomplish, like create an alliance with the parent. Make sure we have a shared goal about what therapy is about. Get everybody to agree to do family therapy. Anybody working with families, anybody working with family therapy knows how hard it is sometimes to help families engage in the family therapy process. It's usually, I'll drop Johnny off at 3, I'll be back at 4. And our job always is to say, Mom, why don't you come on in for a second? Let's maybe I can help you, maybe you can help me. Let's see if we can't do this together, and trying to shift families' perspective about how to help their teen. Now, I've been fortunate enough to be working in the suicidal zone, and there parents are concerned, parents are worried, they are desperate to be involved and desperate to have some solutions on how to help their teen, how to get them through these processes. So we find in the suicidal population, family engagement goes a little more easy. Still can be complicated. Parents can still have ambivalence. Parents still sometimes feel blamed if you invite them to therapy. But these are the challenges of a family therapist. Fourth, the model is manualized. It does have a directionality. Any of you that have studied a manualized treatment, DBT, TFCBT, MST. I mean, most clinicians nowadays have been trained in some empirically supported treatment. And I think the fear of those treatments being overly rigid and stopping my own creativity have diminished. People see that you still have to be a therapist and pay attention in the room. But ABFT is the same. It's got a scaffold, it's got tasks, it's got outcomes, but it requires a lot of the self-therapist. It's flexible and principle-based. Finally, the main thing is that we are based in attachment theory. The history of family therapy has been one of general systems theory, cybernetics theory, really in profound theoretical frameworks that helped us break down the walls of psychotherapy and see that individual functioning wasn't the only process impacting an individual's psychotherapy or psychopharmacology or psychopathology. And that in fact, the environment they lived in might have a buffering effect or a reinforcing effect. And those models helped us think more broadly. But attachment theory offered a clinical language, offered how do I talk about trust? How do I talk about connection? How do I talk about safety? And these are things that I actually say in the therapy room that help guide what I'm doing, whereas general systems theory, I generally would not introduce as a general concept. Got my little cup from Belgium. Now, what do we know about adolescent depression? Adolescence is certainly a critical developmental time. Frontal lobe development, peer and romantic relationships, school problems becoming more important. For many families, they're changing. Parents are getting older, grandparents are getting older, people are retiring from their jobs. So the whole family life cycle is a complex process during adolescence. And for us as family therapists, we're trying to think about how is all of that impacting on the ability of a parent to be available to their child. Unfortunately, depression is on the rise. We could talk a lot about this for a long time. The latest data suggests 18% of adolescents have an actual disorder for depression by the time they're 18. That's a serious change in our culture. COVID certainly has not helped, and something that we all have to be thinking about and going to see a lot of in our clinical practice. We also know that suicide has become a serious adolescent problem. Suicide is the second leading cause of death for young people ages 15 to 24. That's remarkable. You have to really stop and grasp that. Second leading cause of death, not cancer, not car accidents, not other medical diseases. Second leading cause of death. That suggests that when we get a troubled teen referred to us, our data suggest that about 30% of kids referred to the mental health system report suicide ideation. So you really have to be, as this conference is helping you, be up on your game, understand the texture, the landscape of suicide, know a lot about how to assess it, how to when is it a serious problem, when to refer, when to hospitalize. This is a territory we live in nowadays as mental health providers. Well, the data suggests 16% of students report considering suicide. 13 have a plan, which we know is a step up in higher severity. 8% talk about having made some kind of attempt. You line up 100 high school students, 8 of them have made a suicide attempt. How lethal it is, did it need medical care? Yes and no. But still, making an attempt is a serious gesture that has to be understood as an important call for help. When we consider non-lethal attempts, almost 2 million teenagers a year make attempts for suicide, many of which show up in the emergency room, some of which don't. So we're all here today because we're concerned about suicide and know it's a serious problem, trying to get some tools for how to manage it. Luckily, ABFT has climbed the empirical ladder. We've been shown to be effective in reducing suicide, reducing adolescent depression. We have about 6 randomized clinical trials. We're now listed on SAMHSA's evidence-based resource guide, California Clearinghouse, SPRC, we're registered as a best practice. NREP, those of you who remember, we were there as well. And we're on a number of panels of approved services in Europe and Sweden and England. This has been a long journey to become an empirically supported treatment. We're very proud of that, very proud of keeping family therapy on the mental health map. We do a lot of dissemination work, a lot of training. I'm going to talk about that at the end for a few minutes. We have training programs in a number of countries and do a lot of workshops and trainings around the United States as well. Let's get to the foundation of the work. What is the theoretical foundation? And for us, theory is not something we just read about and forget. Theory actually comes right into the room, guides what we think about, helps us say the things we say. So we take theory very important. And I encourage you, if you leave this workshop and feel like, ABFT is fine, doesn't fit for me, find something, find a framework that you believe in. CFTBC, DBT, obviously popular ones. Another family therapy model. Study it up, learn it well, have it in your bones. The more you have a foundation of what you believe is important to focus on and not focus on, what you believe is important to activate in the room, the easier it's going to be for you to make the myriad of decisions about where should I go next? Should I stop that conversation? Should I start this one? There's a lot of decisions, clinical decisions go on when you're working with a family, and having a theoretical foundation can be very helpful. So we start with a theory of healthy functioning, because what ultimately are we doing? Families come to us, they don't work well, they don't function well, there's affect dysregulation, there's poor organization, it's an unsafe environment. And I'm going to work with them to try to move them along a spectrum of health to where they have some healthy processes, more organized, more warmth, more persistence, more consistency. That can vary culture to culture, but there are some core universal principles we now know about family life. And here is where we turn to the basic attachment structure. I'm sure all of you have seen this in graduate school and know this, but this is the basic element of it, and it guides us in the room. A child has an emotional need, goes to his caregiver. Caregiver is available, responsive, and attuned, rubs the kepi, helps the child calm down. Child feels loved and protected. Over time, child begins to believe they are worthy of love and protection, starts to internalize a working model of themselves and their relationship expectations. And if I grow up in an environment that treats me well, takes care of me, helps me regulate my emotional life, I'm more likely to go out and seek other relationships that treat me the same. Attachment theory also helps us think about emotion regulation, which is a very big interest these days in the psychotherapy research world, because so many disorders are about emotion dysregulation. I either turn inward and cut, or I turn outward and explode, but I feel things, they're overwhelming and diffused. I can't organize myself, and I become self-destructive. So how does attachment theory feel? So explain it. Have an attachment need. Kid falls off their bike, runs up the stoop to mom. Mom picks them up, gives them a kiss on the boo-boo, says things will be okay. Child's emotions down-regulate. Child's fears are calm. Over time, kids internalize that skill through repeated experiences of helping me downregulate. I start to internalize those skills and am able to downregulate and self-soothe myself. What does parenting look like in a secure-based family environment? Again, we're still just looking at healthy normative functioning. Family therapy, family life is built on two pillars. I say this to almost every family in my first session. I want them to know where I'm headed, what I'm going to be focused on. Warmth and structure. And it's the balance of these two things that creates a context for healthy adolescent development. When there's too much warmth and not enough structure, kids can be out of balance. These are laissez-faire parents, or love their kids a lot of affection, a lot of sweetness, but don't have them come home at night. Don't help them with homework. You want to drop out of school, it's up to you. You're your own person. Don't provide the structure to move them forward. Too much structure and not enough warmth. Harsh, critical families that are very demanding, but not enough love in the room. I'm doing this because I love you, not because I am trying to punish you. The important thing for us is that in adolescence, attachment is just as important as it is in younger children. We usually think about attachment as a for a toddler, a 3-year-old, running around the room and then getting scared and then running to mom and hiding behind her dress. But years of research have found out that attachment is still operating during the adolescent years. And the old myth of separation and individuation that we all learned in graduate school from Erik Erikson's Stages of Life is really an old psychoanalytic kind of model about how kids grow up. And then really to become independent and become yourself, you got to move across country and leave your family. And how many of us tried that? And when we got there, opened our suitcase and found out there was your parents came with you in these internalized expectations and dilemmas. That the real task of adolescence is just maintain connectedness and develop autonomy, not one at the expense of the other. I still use you as my secure base, but I'm free to go on and try to develop my own sense of self. How many of us still turn to our parents as a secure base? Got a new job, partner got sick, child, made an accomplishment. Hey, I'm going to call mom and tell her. There's still some impulse to want to connect to that base that once was so important in our life. So developing autonomy and maintaining attachment is the core developmental tasks. And we see this in therapy all the time when a mom brings a 16-year-old boy and mom says, he's done with me. He doesn't want my help anymore. And we say nothing could be further from the truth. This boy, this suicidal kid coming out of hospital is adrift. He's in outer space with a very thin rope. And if you don't pull him back to earth, he's going to be lost. So for us in ABFT, we see family as a protective factor. Parental warmth, parental sensitivity. And I don't mean being a mush parent. I don't mean spoiling parent. This is what parents always ask when I talk to them like this. But getting them through an emotional difficulty. When they come home from school and they're upset, you don't scream and punish. You provide warmth and understanding. You still may ground them. You still may say, you got to do extra chores. You got to write an apology letter to your teacher. But you start with what happened? How do you see what happened? Tell me what went on. Must have been so scary for you. And we, from years and years of research, we know this leads to better adolescent functioning. Better grades, better peer relationships, less drug use, better physical health. So what happens when it goes wrong? What if there's not a secure-based family relationship? Child has an attachment need, caregiver fails to be available, child feels unprotected and unloved, begins to develop low expectations of attachment security. We think about the attachment categories. You've all heard of avoidant and anxious and disorganized. We think of them as defense mechanisms. How do I protect myself from being disappointed again? I stop relying on them. Or I never leave mom's side because I'm worried I'm going to lose her. And these are just ways our kids develop strategies, relational strategies. Who do we trust? And are we worthy of being taken care of and loved? Now, when you're doing family therapy work, you have the added dimension of parents having their own attachment legacy. They had a bad childhood. They didn't have many of our clients who come to us with troubled kids, unfortunately, had troubled lives themselves. So their own attachment style might be dismissive or preoccupied or unresolved. And when you got a dismissive parent who's got a kid an infant, a toddler who wants nothing but love and attention, there's a mismatch, temperamental mismatch that can lead to unhappiness and disruption. So for us in family therapy, the parent is as much our patient as the child. We know there are risk factors for insecure attachment, life events, caregiver stress, family interaction patterns. Sometimes we say there's trauma with a big T, abuse, neglect, abandonment. Sometimes there's trauma with a little t, chronic criticism, disregard, harsh punishment. And sometimes kids who develop illnesses can put stress on the system and make it difficult for families to hang in there and do the best they can. This is our map. Based on all of that is our map. We think about the adolescent, we think about their attachment style, their emotion dysregulation skills, their conflicts over attachment and autonomy. We think about the parents, we think about their intergenerational patterns. You all do this if you're therapists. You're always thinking about their childhood and how it has scarred or strengthened them. For many of our parents, we're thinking about their depression, their alcohol use, their personality disorders. And there's current stressors. Some of our parents have economic problems. Some of our parents have marital conflicts. Some of our parents feel discriminated in their community. And then when you have parents with these kinds of challenges, it leads to insensitive caregiving behaviors, not because they're bad people. They have their own onslaught of stressors that block them from being the kind of parent they want to be. But that kind of parenting leads kids to feeling unworthy of love and protection, which leads to attachment ruptures, combined with other temperamental, biological, environmental factors, can often lead to youth suicide. So in some ways, this is an academic model. It's been tested in many studies to show patterns of factors that contribute to youth suicide. For us, this is our clinical map. These are the boxes that guide ABFT. We're going to be working on all of these things as part of our therapy model in order to improve this parent-child interaction. I know that sounds like a lot to do, but let me give you some ideas of how we do it. So what is the clinical model? How do we, guys got lofty ideas. Yeah, save the world, make everybody fall back in love with each other. I got parents that can't do it. I got kids that won't do it. I got people who are too hurt. We know we work with the hardest of the hard cases. But let me offer some scaffold, some structure that helps me move at least 75% of our cases along the road to health. Essentially, we see family as the safety net. We're trying to sell to the parents, you are the medicine. If I could help you feel stronger with your kid, if we could revitalize a secure base, your kid would be safer. And the next time they think about suicide, they'd come to you for help instead. The treatment manual is principle-based, I've said before, goal-driven but flexible. If anything, it helps you be more intentional. Every session, there's things you're trying to accomplish and things you're trying to set a foundation for the next session. And for us, the person of the therapist is critical. Your ability to be close to people, to challenge people, to tolerate difficult emotion, to take people into some of their darkest places. A lot of that turns out to be us. And what do we like to do? What are we capable of? There are 5 tasks generally. No, there are 5 tasks that we think about that guide the work. It's not rigid. There's all kinds of things we might do within a task, but each task gives us certain parameters of around what are we trying to accomplish. Generally, task 1, the relational reframe, is about getting parents to buy in to family therapy, parents and kids. Adolescent, we then meet alone with the adolescent and try to develop an alliance. When kids are 7, parents just bring them to therapy. When kids are 16, if they don't feel like there's something in this therapy for them, they're not coming back. We meet alone with the parents and try to work on alliance, build safety and trust, build bond, build shared goals about the therapy, and build common task goals that we're going to try to accomplish. These are complex tasks. We're going to see a little bit of the territory landscape of them. When we feel like we've prepared them, we bring them back for the attachment task. And here we're often helping kids talk about the things that make it difficult for them to go to parents for help. There's a whole range of things that we're going to see. Once we get some reparative work going on in the attachment structure, we turn to promoting autonomy. What is the relational reframe goal? It's to shift from patient as the problem to family as the solution. Not family as the problem, but helping parents see, helping kids see that if you guys could feel more connected, I think it would provide a buffer for all the stressors that's making Johnny feel like he wants to hurt himself. And here's our defining question that sets really the whole tone of the therapy that we say every case about 45 minutes into the first session. When you're in your room and you're thinking about killing yourself, you're thinking about you want to die, and your parents are downstairs watching television, why don't you go to them for help? Why is the attachment switch off? Why aren't you using them to protect you just like you did when you were 7? And in trying to activate parental caregiving instinct, we know parents can be mad about the suicide, frustrated about what's going on, but we lean into their attachment caregiver instinct and say, must break your heart that he didn't come to you. I know how much you love him. I know how much you worry about him. Wouldn't you rather he comes to you than hurts himself? And we try to have that conversation, activate that kind of conversation, block problem solving. We do a lot of intake in the beginning, covered the problems. We know what's difficult. We say, Dad, we're going to get back to the substance use, and I know school's a problem, but I'm just worried your kid feels so disconnected that he can't even use you to protect himself from hurting himself. And our goal, the reframe task, it's a complex task. You're going to see a videotape of this, but it's to establish relationship repair as the first treatment goal. Not getting them back to school, not star charts on the refrigerator, not getting them up in the morning without a conflict. We say all these behavioral conflicts will partly resolve if you two feel closer to each other. And we have a whole way that we try to sell it. We then meet alone with the adolescent, trying to build a bond, get him to buy into the goals of this therapy and the task of this therapy, meaning, would you come to family therapy and talk to your parents about these problems? Generally, the texture of this, we usually 3-4 sessions sometimes. We explore their current life, try to find some strengths and, goals. Then we get into the problem narrative. What is it? What are they happy with how their life is going? Trying to help them take a little ownership of this therapy process rather than saying, "Oh, this is my mom's therapy. They just drag me." We say, "Yeah, I get it, but he just came out of hospital. You got kicked out of school. Your girlfriend left you. Sounds like you might not be happy. Can you own that a little bit? Does part of you want to feel better?" We want this therapy to be their therapy. From there, we move to the attachment narrative, where we try to help them better articulate what are the things that have happened in this family that have made them feel like they can't trust their parent, can't go to their parent. And then we try to link some of those family problems to the mental health problems. I'm worried you were so furious at your father that until you work through some of that, you're going to continue drinking yourself to death. That when you go out and drink the way you do, it's not because you're an alcoholic, it's that you are trying to cover up the rage you feel when your father beats you the way he does. Trying to help them make links between their acting out self-destructive behavior and some of their family disappointments and conflicts. It's not the only thing contributing. There's peer groups, and we know that. But why are we doing this? Because if we can make that link, we can say, if you'd come to the next attachment task and talk to your father about how you feel, I think it would get some things off your chest, help you feel better. What are the kind of things they say when you finally get to the attachment narrative? My mom didn't protect me when dad was abusing us. How can I trust her now? My dad doesn't accept me. My mom's critical and controlling. My parents don't understand me, just try to solve problems. Or the parent who's overly anxious or depressed. I tell my mom what's going on and she freaks out and gets anxious and calls the school. And I'd rather not burden her. 50% of our depressed kids say, I don't go to my parents because I don't want to burden them. They got enough on their plate. We meet alone with parents. And here also, we're trying to create a bond. They think we're here to blame them. We want to shift that. We want to be their advocate. There's a whole landscape of things that we do with them, things that you do with them also. We just do them in a little more systematic way. Part of our interest is current stressors. That can be work, employment, unemployment, health problems, that these things are getting in the way of them being good parents. We try to do a little intergenerational work, help them think about their own mental health history, their own disappointments with their parents. And what do we often inevitably find? I promised I wouldn't treat my kids like I was treated, but unfortunately, I'm doing exactly to them what my father did to me. It's not always the story, but it's often the story, some version of the story. And what do we say? How do we try to motivate parents to work through this? We lean in with empathy, not criticism. When you got a lot on your plate, we say it's hard to raise an adolescent, let alone a depressed one, let alone when you're depressed yourself. So we sort of try to empathize with current stressors. From the intergenerational perspective, we might say something like, look, nobody was there for you when you were growing up. And now it's hard to know how to be there for Billy when he's growing up. So these are insights that we often say. You've said all these things to all your patients. We're just making sure we're saying them from a position of admiration and empathy and strength and motivation to say, how would you like to now be for your son what your mother never was for you? And try to link this conversation, this insight about their life, as a motivational tool to help them want to be different for their kid now. We then bring them to the attachment task. We sort of think about this as shuttle diplomacy, right? We've met with the kid, tried to understand some of their problems. We've met with the parent, tried to understand their perspective. We've had the kid try to identify what he wants to talk about to his parents. We hope the parents be more open to hearing what the adolescent has to complain about. Not that it's the whole cause of everything, but that maybe you haven't been listening enough to his pain. Take divorce, for instance. How many of our families have struggled with divorce? And when you ask them if they ever talk to their kids about it, the parents say, oh, no, I don't want to upset them. And yet the kids are filled with fantasies, filled with anger, caught in a loyalty bind, so many psychological knots. And we want to help moms think, oh, you think I should let him talk about those things? I should listen to how he feels? I should help him work through some of that? Yeah, that's what we are. The attachment task is a complex, in vivo, experiential. It's more like a, I don't know if any of you have done a two-chair technique. It's more like a Gestalt. It's kind of the enactment of structural family therapy, where it's actually people talking to each other rather than you doing all the talking. The goal is multi-layered. On the one hand, I'm trying to help kids and parents resolve actual conflicts. On the other hand, I'm trying to change the relational expectation. Oh my God, my mom actually listened to me. She didn't fall apart. She didn't yell at me. Maybe I can go to her for help. I'm helping them practice conflict resolution skills and emotional regulation skills. And I'm trying to create in the very conversation itself, if it goes well, can be a corrective attachment experience. Mom listens, supports, empathizes, child shares pain, discomfort, confusion. Just like when he fell off his bike, I go to my mom for support when I'm hurting. So the very conversation itself, the process of the conversation is a reparative experience, let alone working through the content and the skills we're trying to develop. A couple of those sessions can be quite rewarding for families. We move on to the attachment, the autonomy task. Here, we're trying to revitalize a goal-corrected partnership where cooperation becomes more important for kids. Mom's kind of on my side now and kind of like it when she takes care of me. I'm going to take care of her. I'm going to come home at 9 o'clock. I'm not going to break curfew. I'll try to clean my room. They become more cooperative when they live in an environment where they feel loved and respected. And it can be a task where we're talking about all kinds of other, this is often where we're talking about sexuality, religion, LGBTQ, dating, the future, college. Now that they have more sensitivity with each other, they can take on the difficult topics of life. Do we go back to a task 4 at times? Absolutely. Do I sometimes I'm in task 5 and I think, oh my God, I got to go back to task 3 because mom's kind of getting defensive again and I got to shore up her skills. It's a fluid psychotherapy, just like you would, but I have a map. I know that if I want to deal with the skills to help mom stay in the saddle of availability, I'm just going to meet alone with her for 15 minutes and reminder of some of our task 3 conversations. Let me show you a videotape. Give you an idea, a little idea of how this looks. I should say these are actors. This is scripted. These are based on real cases. It's only 7 minutes, so the therapist is moving fast. So it doesn't look what real therapy would look like, but it does demonstrate the particular skills that I want you to focus on and that we've been talking about.
So here you are, James, feeling all alone, worthless, sometimes even hopeless, and maybe using the drugs a little bit to numb that pain. I'm wondering, when you are in all that pain and struggling at school and all these things are happening, why aren't you going to your parents for help?
I just don't get it.
Tell me more about that.
I should say this is about 45 minutes into the first session. We've done a lot of joining. We've done a lot of history taking. Why are you here? What are the problems? School, substance use, delinquency. We get it. It's a serious problem. Now we're going to think about shifting to the relational themes.
Months or something to let me know, and by then it was too late. Still having my friends goodbye because they were already on vacation.
Yeah, so you feel like they don't get you around the move, and it sounds like maybe even since then, when you've been struggling with things, do you also feel like they haven't gotten you, that they don't understand what you're going through? So it's almost that you can't even maybe trust that they're going to be able to help you if they don't understand what you're dealing with. Would you say that's the case? How about for you guys? Jennifer, what do you think about what James is saying about not understanding?
Well, I want to understand him. I admit I don't understand the drugs, but I want to understand him. But he doesn't talk to me like he used to.
So you really have that desire to understand, and know what's going on. But there's something happening here that he won't come to you.
Yeah, we used to be close, but not anymore. He won't spend time with me. He won't talk to me.
How about if you, Henry? What do you think about James saying he doesn't come to you because he feels like you don't understand?
I'm right. I don't understand. I worked hard to provide a good life for him, and certainly a better life than I had growing up. I mean, yeah, I don't understand why he's upset.
I can get that. You really worked hard to provide a really good life for your family.
The boys do miss you. We talk about you getting to, go to more games and do more things with them, and you just never seem to make time on your schedule.
So it sounds like there's, Mom, that you're saying that there is a lot of space where Dad isn't able to be there. Is that how it feels like for you, James? So then you had to sit with all that pain alone. And I wonder, you said you kind of felt lonely in school and out in the world because you were having difficulty making friends. I also wonder if you were feeling lonely at home. So on top of it all, you're feeling lonely in the house too. And that's just adding to your. Mom, I saw you shaking. What's that like for you to hear?
It just breaks my heart. I feel like I failed as a mother. I don't want him to be sad. I want him to be happy and have a good life, and that's what we were trying to do.
You really love your son.
I do.
I'm wondering, for you, Henry, what is it like for you to know that kind of James is feeling all alone? Part of the reason because he can't come to you.
I mean, I have always thought I was a pretty good father. Certainly a good provider. Maybe I'm not, but
it's really a hard thing to do, a really brave thing to do. I'm wondering, what is that like for you to hear your father say that maybe he's not the best caregiver?
I never said that you were like a bad father, that, you know, you didn't take care of us.
But I mean, I'm not Superman, you know. I mean, I've had my doubts about this move as well.
But for you, you really, you know, you're not sure everything is right, but it's clear. I guess what I hear from there is you really love your son. But also, I see, I mean, it seems like, James, you don't really know your dad that well.
I mean, I thought I did.
And I also really, I mean, the way you just defended your dad here, I also, even though you're really angry with both of them and what's happened, I feel how much you actually love your dad too. Maybe even admire him.
I do.
There's been such a disconnect between you guys. I'm wondering if, do you want your son to know you better and to know your son better?
Of course I would, yeah.
You tell him that.
You know, you're a son. I want to know you better.
What's that like to hear from your dad?
Well, it's nice to hear.
Do you want to know your dad better? Have him love you better. And Mom, what's that like for you to see that?
It's what I've longed for. I mean, I know they love each other, but they just never seem to be able to connect.
And it seems like everybody in this family has really been disconnected for the past year. And that's really what I want to help you guys with. I want to, you know, I know there's a lot to work on. There's a lot of school issues and there's the drug issues, but I really see that this disconnection is really our first obstacle to tackle. That this disconnection is really preventing you guys from being able to help James, and James, you being able to go to them for help. In order for James to get better, the first thing we need to work on is getting you guys connected again, helping you guys know each other and reconnecting you. Is that something that you guys can agree to?
For me, absolutely.
Even
Well, you know, if this is the right way to go, then yeah, of course.
how about you, James? That's wonderful to hear. I know that if we can get all of you guys connected again, which we will, that we're going to help get James feeling better and addressing all of the concerns that all of you guys have.
So we've moved the conversation of the therapy from behavior problems, school, substance use, to relational problems, to the disconnect, to the loneliness that everybody feels. And that becomes the leverage. Everybody can engage in that goal of therapy. Kids feel less blame, parents soften, feel more motivated, that love is in the room, and that's what we're trying to reestablish, particularly for families who've been through some pretty bad hardships. For those interested in this work, if you'd like to learn more about it, we have a well-developed training program, introductory workshop, year of supervision, called multiple levels of certification. But what is our closing statement? ABFT is about relationship building, not behavior management. We get to behavior management, but we think relationship building sets the foundation. We focus conversations on the relationship is more engaging for family members, particularly the teen. And finally, you can have a theory and a structure and a model and still apply it with great artistry. Still requires you to manage the subtleties in the room, the processes in the room. And we encourage you to find some framework for yourself that provides some of that for you. If you're interested in hearing more about our work, I'd reach out to Suzanne Levy, the ABFT International Training Institute, Suzanne Levy, abftinternational.com. Thank you very much for listening.